A common parental concern is, if my child has a history of febrile seizures, should I administer antipyretic medication immediately when their fever reaches approximately 38.5 degrees Celsius? The simple answer is yes. For a child with a known history of febrile seizures, it is medically advisable not to allow the fever to become high, as there is a significant likelihood of seizure recurrence. However, observing a child during a seizure often induces significant panic and fear in parents, leading to uncertainty and improper actions. This guide aims to address key questions. Why do high fevers cause seizures in children? Are they dangerous? What are the correct and incorrect actions to take? What if the fever does not subside after medication? When is hospital admission necessary? Instead of a simple yes-no answer, this guide will provide a comprehensive overview to empower parents to manage febrile seizures calmly and correctly. Pathophysiology and epidemiology. The complete mechanism of febrile seizures is not fully understood by medical science. However, three primary hypotheses are widely accepted. Increased neuronal excitability. Fever raises the core body temperature, which is thought to lower the seizure threshold by making neurons more excitable than normal. Respiratory alkalosis. Fever-induced hyperventilation can lead to hypocapnia, or a decrease in blood CO2 levels. This causes respiratory alkalosis, a condition that also increases neuronal hyperexcitability. Inflammatory mediators. The febrile response involves an increase in inflammatory cytokines, which may in turn upregulate certain excitatory neurotransmitter receptors in the brain. Febrile seizures are most common in children from 6 months to 5 years of age. Simple febrile seizures typically cease to occur as the child grows older because the central nervous system matures and becomes less susceptible to febrile stimuli. Risk factors for febrile seizures. The predisposition to febrile seizures is influenced by several factors. Genetic predisposition. A family history of febrile seizures is a known risk factor. Age. The highest incidence is in toddlers aged 12 to 18 months. Fever characteristics. A high fever that rises rapidly is a common trigger. Underlying cause of fever. Fevers following viral infections or certain vaccinations can trigger seizures due to the intense immune system stimulation. However, the incidence is low, and the benefits of routine vaccination far outweigh this risk. All children should adhere to the recommended vaccination schedule. Key considerations during a febrile illness. Parents should be mindful of two critical points. Presence of a serious underlying illness. The fever itself may be a symptom of a dangerous underlying condition. Focusing solely on fever reduction without identifying the cause can be hazardous. The nature of the seizure. It is essential to differentiate between a simple febrile seizure and a seizure caused by a more severe neurological condition like epilepsy, encephalitis, or meningitis. While the simple febrile seizure is typically not life-threatening, the panic it induces in parents can lead to harmful interventions. Therefore, if a child experiences a seizure for the first time, they must be taken for immediate medical evaluation to rule out dangerous underlying causes. If a child has a documented history of simple febrile seizures and returns to their normal baseline after the episode, continued monitoring may be appropriate as advised by a physician. Differentiating simple versus dangerous seizures. Simple febrile seizure, characterized by lasting less than 15 minutes, being generalized, affecting the whole body, and not recurring within 24 hours. After the seizure, the child returns to their normal, playful self. Complex or atypical, dangerous seizure, characterized by lasting longer than 15 minutes, being focal, example, confined to one limb, or recurring multiple times within 24 hours. Management protocol for a child with a history of febrile seizures. The priority is early fever control. Do not wait for the fever to become high before administering antipyretics. During an active seizure, remain calm. Administer a rectal antipyretic. Use a paracetamol, acetaminophen, or ibuprofen suppository as prescribed. This is the recommended route as the child cannot swallow safely. It is advisable to store these suppositories in the refrigerator to maintain their firmness for easier insertion. Remove excess clothing to aid in cooling. Apply tepid compresses. Use lukewarm water for sponging. Actions to avoid. Do not insert anything into the child's mouth, including fingers or cloths, out of fear of them biting their tongue. The risk of a significant tongue injury is very low. Conversely, placing objects in the mouth poses a high risk of obstructing the airway, causing injury, or inducing vomiting and aspiration. Summary of management. When a child with a history of seizures develops a fever, administer antipyretics early. If a seizure occurs, remain calm, administer a rectal suppository, remove excess clothing, apply lukewarm compresses, and place the child in a safe, stable position. Example, on their side. If there are any signs of a dangerous, complex seizure, seek immediate medical attention to determine the underlying cause.